Welcome everyone. Today we bring attention to multiple myeloma, a type of blood cancer that often goes undiagnosed until it reaches advanced stages. Early detection is key, but many cases are missed because symptoms are vague. That's why the role of pathologist and hemato-oncologist is so important in identifying and treating this disease as soon as possible. Our panel today will explore the latest advancements in diagnosing multiple myeloma, including improved lab tests and genetic insights. We will also discuss new treatment options from chemotherapy to targeted therapy and how they are helping patients live longer and better lives. Beyond medicine, we must also focus on patient support, ensuring that those diagnosed have access to the care and guidance they need. Let's get started on this important conversation in this virtual panel on multiple myeloma uncovered, advancing early detection, treatment, and support, organized by Voice of India. Join me in welcoming Dr. Kunal Sehgal, MD, hematopathologist, and flow cytometrist, Director, Newberg Sehgal Path Lab. Welcome, sir.
Thank you so much, Manisha.
Dr. Subhaprakash Sanyal, Director, Fortis Institute of Blood Disorders, Fortis Hospital, Mumbai. Welcome, Dr. Subhaprakash.
Thank you.
Dr. Abhay Bhave, Senior Consultant, Hematologist and Bone Marrow Transplant Physician, SL Raheja Hospital. Dr. Bhave, I can't see you. Are you there? All right. All right, no problem. Dr. Akanksha Garg, hemato-oncologist and bone marrow transplant specialist, Zydus Hospital, Ahmedabad. Welcome, Dr. Akanksha.
Hello, thank you so much.
So, Dr. Prakash, can you help us understand multiple myeloma and how it differs from other blood cancers?
Hi. So the question is very pertinent, I believe. So when we talk about a blood cancer, the very common language is basically blood cancer equal to leukemia that we understand. And when we talk about the leukemia, it is basically we understand that leukemia is a AML, ALL type of leukemia, but multiple myeloma is not commonly perceived as a blood cancer in community. So if you ask me how it differs from the other blood cancers, there are four things I think extremely important. So multiple myeloma has no specific symptoms. Patient may have little bit fatigue, not feeling well. They have little bit backache. They are not comfortable in doing their day-to-day work very properly. So backache is again a very common symptoms. Most of the times, if you ask any orthopedicians, if you see the 10 backaches, what you do, and they have their own answers ready. But to pick up from the backache, the multiple myeloma backache is sometimes is not very easy. So diagnosis is sometimes is challenging because most of the times multiple myeloma patients don't come to the hematologist straightforward. They go to the physician due to the fatigue. They go to the orthopedicians due to the backache. They sometimes landed up to the nephrologist with the kidney problem. So there are a lot of variable type of references we get in the multiple myeloma issues. So this is one way it is little difficult. And another problem is that in multiple myeloma, many times you see that hemoglobin is not very bad. They're low, but not very bad, like a 10, 11-ish like hemoglobin. So many people feels that, many physicians feels that 10, 11 hemoglobin is probably is a very right type of hemoglobin in our country, and they don't work up further. A little bit they work up for, and then they found, okay, 11-ish hemoglobin is, let's better ignore it. So these are the common challenges in multiple myeloma. So this is the particularly the very basic thing about in the community level, I believe, that it is different because another issue is that if you see the peripheral smear, you can diagnose acute leukemia very easily, but you don't have any clear-cut peripheral smear diagnosis from the multiple myeloma. You can get some suggestions like a ruler formation and all this stuff, but not very clear-cut. So a lot of things to interpret and then to ask for the myeloma investigations, I think extremely important. So this is that way, it's little complex in the etiology, complex in this scenario from the other than hematologist point of view to diagnose myeloma. So that is the way it is little different from the acute leukemia or blood cancer from the in general.
Right, sir. So the symptoms are really vague and it becomes difficult to diagnose and then pick it early. So, Dr. Akanksha, when it comes to early detection, what are the warning signs and symptoms that patients and their family should be aware of?
Yeah, so many of the symptoms have been alluded to by Dr. Sanyal, but I would like to add, like, myeloma is basically the cancer of the plasma cells, and it basically affects the bone as well as, your kidneys. So if you have any subtle symptoms, kidney symptoms, like, there is any alteration in the urine frequency, or you feel that, you're getting edema in the feet, which is like the swelling of the feet, that, it could be pointing towards something, there is a problem in the kidneys. So at this point, the patient should go for detailed kidney testing also. And many a times, I have had patients who have had unexplained anemia. So one of the features of myeloma is that the patient starts having anemia. So the patient was having taking hematinics for quite some time, but the anemia was not improving. And then she presented to me. So then at that time, of course, with anemia, you have 100 other reasons rather than just thinking of myeloma. So then doing a LFT, simple, looking at the protein albumin, you can get an idea that, yeah, there is basically the components of the protein, which is the albumin and the globulin. So what happens in myeloma is that the globulin proportion goes up. So that is also one of the subtle signs. So many times, majority of the cases are picked up through certain blood tests. Again, bone pain is very non-specific. So in early stages, the patient may not even recognize that as a something which is of huge importance. Then because later on when patients present, it is mainly either through kidney failure or fracture. So that is not the point where we want to detect the patients. It is mainly early on when we want to pick up. So I think doing blood tests, regular screening of your CBC or LFT kidney functions is important. Obviously after a certain age, when you're above 40, 50, you should have those tests regularly, and that would help in picking up the subtle signs and symptoms of your disease, which is the plasma cell dysplasia, myeloma.
Right. So bones are affected, kidney failure can occur, and definitely globulin it increases. Right, ma'am. Dr. Abhay, can you tell us, are there any specific risk factor or population groups that are more prone to developing multiple myeloma? And do you think genetic predisposition play any role?
Thank you, Dr. Manisha. I think you asked me two questions. One is, are there any risk factors towards developing myeloma? And the second one is genetic predisposition.
Right.
So, as far as risk factors are concerned, uh, it would appear that certain chemicals, pesticides, benzene, toluene blue, certain chemicals can change the DNA structure. Now, that's not specific for myeloma. It can occur in any kind of malignancy because it plays with the DNA, and therefore the DNA tends not to repair itself well, and therefore the chance of getting any type of cancer is higher. So also it will be for a condition like multiple myeloma. As far as genetic predisposition is concerned, um, I used to say before that I did not think that one family, many people in the same family will have myeloma. But now with an improvement in the follow-up, I've got at least three or four families now where there is myeloma in the same family, either brothers or father and son. So I am seeing some kind of genetic predisposition, but among the vast number of myeloma patients that I have, seeing three or four families doesn't make much of a difference. That means I don't think it is a high incidence, and I don't think someone who gets myeloma in the family should be worried that others could get it. Tomorrow's world is going to be about, I feel, is going to be about biomarkers. So if we are able to pick up certain biomarkers which could be related to genetic predisposition or which tell us that there is a likelihood that you can develop. For example, in one of the Scandinavian countries, MGUS is a high incidence and monoclonal gammopathy of uncertain etiology, uncertain significance, which later on can lead to myeloma. So that pickup sometimes is an early pickup. And there's a predisposition to developing that condition and that condition becoming cancerous. It is by accruing more genetic mutations. So we are learning more and more, and as time goes along, I think we'll be able to tell genetics far better. But currently, the risk factors such as smoking, alcohol, obesity, all that we say, they're add-on factors. They are not actual risk factors for developing myeloma. But yes, if we had them, they would add to the unhealthiness that the patient has, predispose them to either shift to myeloma or make the myeloma more difficult to treat. So There are no specific genetic factors that are there. As time goes along, we will learn them, especially as we start doing next generation sequencing upfront in our myeloma patients. We pick up which genes are associated with a higher chance of developing myeloma. But so far, we don't have that data in our country. There are trials in the US and UK, Australia, where they're doing NGS upfront and they might be able to pick up these genetic variations. Otherwise, my opinion is that the family should not be anxious. That if one person has myeloma, others can develop myeloma. It is very less likely that will happen. You must remember there are two types of genetic mutation which take place. One which is germline, which is coming from generation to generation, and one which is somatic. 10% is only germline. 90, 80, 90% it is going to be somatic. Somatic means mutations as part of your survival. So mutations which are somatic are very specific to that individual's life. It is less likely going to go from generation to generation. Therefore, the chance of this being genetically inherited is less likely. All diseases are genetic. All diseases are genetic. So it all depends upon which gene has gone wrong. And in my last point, you might have a gene, let us say, predisposing to myeloma. But that doesn't mean you will develop myeloma. It has to be able to express itself enough to be able to cause myeloma. So if you do your and my gene analysis, we have so many mutations that give rise to so many diseases. We are not reading all of them. So having it, genotype and phenotype are two different things. Everyone need not have it. But when your body becomes unhealthy, start getting mutation, then these get a chance to express themselves and the disease comes.
Right. So as of now, no familial tendency, but we are doing genetic testing and NGS is coming up. We might have more insights in future. Very well explained. Dr. Kunal, with the advancements in diagnostic tools and molecular testing, how has approach to diagnosing multiple myeloma evolved over the years, especially from a pathology point of view?
So, as my colleagues explained, this is a multimodal disease. Symptoms are different, presentations are different, diagnostic approaches are multiple. It's not one way. I'll not stress on the radiology, but if you see evolution of diagnostics, on the radiology side, you should do skeletal survey. Okay, age-old wise. Now, today's age, you have MRI and a PET CT available. On a blood test, everybody knows M band was a traditional band which you saw on paper or agarose gel electrophoresis. Okay, which still the modified, fine-tuned, better techniques of serum protein electrophoresis, which are now available by capillary methods, are available, which is what we traditionally do in our labs today. But you also have evolved to immunofixation and immunosubtraction, where we can subtype the M band into the different immunoglobulins. And more importantly, over the last 10, 15 years, with the easy availability of free light chains, that I think has completely changed the approach from both the clinical and follow-up point of view, because a simple blood test is there. Now, while we do at a blood test level, when we go to the bone marrow, traditionally we are doing the aspirin biopsies, but obviously now we have the advent of flow cytometry. We have the advent of next generation sequencing and fish testing for prognosis. While fish has been there for a long time, for the last year from our lab also we now have the availability of the NGS or the plasma seq test for sequencing of the plasma cells. And the evolution has been that when it is a frank myeloma of 70%, 80% plasma cells in the bone marrow, the clinic patient was presenting with typical lytic bone lesions, fractures. Clinician knew the diagnosis based on the M band, liver function test, Dr. Akanksha said. The combination of all this, it was there. The challenge comes in patients who have 7 or 8% plasma cells. And that's where the advent of newer tests like flow cytometry can tell you, okay, these are clonal. Yes, majority of them are abnormal. And then, yes, this is likely to be a plasma cell in your plasma. So obviously, it's evolved over a period of time. And I think it's one of the most rapidly evolving field as far as diagnostic in blood cancer is concerned. I would say myeloma and CLL are on the top two rapidly advancing fields, both from the treatment angle and obviously the lab has to stay neck to neck as far as diagnosis is concerned.
Rightly said, when the percentage of plasma cell in bone marrow is less, then of course these molecular testing and advanced testing like flow cytometry, they help us. So, Dr. Prakash, could you highlight the role of biomarkers, genetic testing, and imaging in the early detection of multiple myeloma and how it contributes to faster clinical decisions?
So there are 3 points. One is the biomarker, genetic testing, and imaging. So
Right.
to my understanding, in diagnosis, you can get some clue from the CBC or what Dr. Akanksha mentioned about the albumin globulin ratio reversal. So these are you can get clue. The most important test is always believed to be the serum protein electrophoresis with immunofixation, where we can pick up the M band, which is the sole pathological marker of the any plasma cell dyscrasias. And this M band is what type of M band it is, how is the couple and the ratio is doing, how is the immunoglobulin levels are, whether there is a immunoparesis or not. Immunoparesis means the one immunoglobulin which is actually the diseased immunoglobulin which is high and others are low. So this is the way you can pick up those disease. Uh, Imaging, we generally don't do any more skeletal survey. We move to the either PET scan or PET CT or MRI skeletography, where we can get detail about that, whether any lytic lesions present or not, or any extramedullary deposits, extramedullary mass is also present or not. So it is basically gives a very fair idea that it's how the bone is damaged, how bad is the bone about the particular patient. Genetic testing, if we ask me this particular question, the genetic testing we generally don't do routinely any genetic testing for the multiple myeloma. We do definitely bone marrow aspirate biopsy and the flow, what Dr. Kunal already mentioned. I generally don't do any NGS for multiple myeloma at this stage, but fish definitely we do from the marrow, which gives us a very fair idea that how good is the myeloma or how bad is the myeloma. So that approach we can do, and few other markers like LDH, beta 2 microglobulin gives us very fair idea about the prognostication of the disease. So you can consider these as the biomarkers of the multiple myeloma, I believe.
All right, sir. So fish is one technique which is helpful in prognostication, and definitely flow cytometry is helping us. Dr. Kunal, one of the critical challenges in is diagnosing relapsed or refractory multiple myeloma. What are the key challenges from a diagnostic perspective, and how can we overcome these with more advanced testing protocols?
So, from a blood test or a bone marrow angle, this disease we know is a waxing and waning disease. There are different time points at which the patient is being followed up. Someone who is recently diagnosed, we continue to follow up the free light chains, and at the end of a certain time point, or for example, a pre-transplant scenario, a bone marrow might be done. At this time point, it is well known that if this patient say is eligible for transplant and is going ahead for transplant, there are known prognostic indicators. For example, if the patient is in complete remission or a partial remission. If it's in complete remission, we need to know whether it's is it also negative by flow cytometry MRD. World over, there's NGS MRD. It's not yet come into practice in India, but is it minimal residual disease negative? Because we know if it is negative, it's a good prognosis. If it's positive, it's a poorer prognosis compared to the negative ones. So the availability of MRD testing at certain time points, like pre-transplant or a post-transplant scenario, really helps us pick up, identify these potential patients who may relapse at a later time point or who may have a worse prognosis. But as Bhave sir was always pointing out, like in genes, just one report of being negative or positive does not always make the patient that is bound to 100% relapse or not relapse. Because we know certain patients who are also MRD positive but stable over periods of time, or the disease is under control. Okay, so there are, unfortunately, myeloma is labeled as one disease, but we know now genetically and based on the different probes, there are actually multiple diseases, genetically multiple disorders, and the patients behave differently. So that's where again, as Dr. Sanyal was also pointing out, at diagnosis itself, mutations like a TP53, bad prognostic like 1Q gain, 1P gain, these kind of bad prognostic markers, if they are there, we know this patient is going to possibly behave aggressively. So, following up on those markers at a follow-up time point becomes important and challenging. So this will be from a more, what I said is more from a bone marrow and a flow cytometry point of view. Obviously, you'll have to do radiological evaluations. Obviously, you have to do the free light chain evaluations. So it's multimodal again. But these are the things which you do in practice.
Right. So MRD analysis is important for follow to see if the patient has the tendency to relapse or not. Right, sir. So, Dr. Prakash, why is early diagnosis so critical in multiple myeloma, and what do you see as the biggest barrier to timely detection in India, especially in underserved regions?
So why early diagnosis is needed and what are the biggest barriers? So two questions are very different. So early diagnosis is important because multiple myeloma, to my understanding, affects the three main organ of our body. One is the bones, one is the kidney, and third is the immune system. So if myeloma is not diagnosed properly, patient can land up with a bad bone fracture, spinal fractures, and sometimes it's very debilitating for the patient. Patient landed up with a nephrologist with a bad kidney, renal disease, dialysis dependency. All these problems can happen. And third, you can get a lot of infection complications, particularly the pneumonia, urinary tract infections, if they are not picked up early. So these are the three areas of the multiple myeloma causes devastations. So if you ask me the biggest barrier that I mentioned my introductory question, that the myeloma patients never comes to hematologist most of the time first. So they go to the backache, they go to the orthopedicians, they take some treatment for the backache and if not settled, they go so here and there and ultimately landed up with the hematologist. Other thing is that many times they go to the nephrologist and the nephrologist uses their own way of doing things and they pick up the myeloma so they are actually not a very just if there is a hemoglobin is low, weakness or fatigue happens or low platelet happens, patients tend to land up to hematologist. In multiple myeloma, particularly these things never happens. Many times I see the myeloma patients are moving with the physicians for a long and then ultimately picked up some imband and then comes to us. So these are the real challenges in that. So I think the physician level, particularly the orthopedicians level, I think the awareness of the multiple myeloma to be spread so any sort of thing, any unexplained anemia, where the ESR is high, any albumin globulin ratio is altered, there is a back pain, there is a kidney reports a little bad, they should go for at least myeloma testing to pick up. That is the only way you can find more myeloma. So honestly, I can tell about my hospitals. My orthopedicians are extremely smart in their routine algorithm in the backache. If they feel little something not very commonly they are seeing, they do immunofixation quantitative straight away and they pick up a lot of myelomas for me. So that is the way things should move.
Right. So I think orthopedicians should be aware of
Yeah.
this, that the backache is a common symptom, and
Nephrologist
it
most of
should
the time
certainly.
picks up their diagnosis very early, but I think the orthopedicians should be more aware of this particular
Okay.
area.
Right, sir. Dr. Abhay, in terms of treatment, what are some of the most significant advancements you have seen in multiple myeloma care over past few years? Sir, please unmute yourself. Dr. Abhay.
Sorry, what was the question again?
Yes. So, in terms of treatment, what are some of the most significant advancements you have seen in multiple myeloma care in past few years?
Oh, I think several, and all the clinicians who are on this panel, we are all very, very impressed with the way the world has done research in multiple myeloma. It's one of the most researched malignancies in the world, and the amounts of treatments available for it are very high. Remember, you can only treat if you've got better diagnosticians. We are fortunate to have people like Kunal with us who make diagnosis for us. Remember, from diagnosis, there are targets. From targets, there are therapies. So we've got scientists who are able to pick up targets, better targets, so more therapies for us to use in clinical practice. So what are the advancements to me? I think number one, awareness. And Sanyal spoke about awareness. I must say that in the city, the awareness is high amongst most of the orthopedicians, nephrologists, physicians, even gastroenterologists who get this diarrhea, and sometimes we pick up myeloma out of that. So the awareness is quite good. I think if you start moving away from cities, maybe it's because awareness campaigns are not enough. Programs such as what you are doing just now helps to convey that awareness. So I think one of the biggest changes has been awareness. Second is attitude. Attitude of us, the clinicians. In the past, when I was studying, we had only melphalan and prednisolone. It was called the standard Alexandrian protocol. You would give MP melphalan and prednisolone, and जो जिया वो जिया, जो नहीं वो नहीं. So from there we have come now to a time when we've got four drugs up front, quadruple therapy. And what therapy? So attitude of the clinician that no, we will not give up. An attitude where not only to the younger patients, remember Indians, Asians tend to have younger myelomas. Otherwise, in the Western state, Caucasian population, the myelomas are in the late 60s, 70s, and 80s. Even in our country, those who are 70 and 80 I've got between 80 and 90, I've got now 8 patients who are on treatment for myeloma, and they're tolerated very well. Attitude, our attitude. We say, no, don't give up, we can still treat you. I think that's a great advancement. Third, availability of drugs, availability of tests, availability of talent such as, Kunal, his team, and other pathologists, histopathologists. You need these people to diagnose. You might be suspecting, but you need proof. They provide the proof. Fourth, availability of insurance. More people are insured. So they're coming forward. They're doing tests. Therefore, we are diagnosing. Others are not able to diagnose. Cross referrals in hospitals from intensive care to nephrology to hematology, ortho to hematology. Cross references have increased. That has made us diagnose much more. Availability of supportive care, good supportive care. We are giving treatment, but if they get side effects, we are able to bring them out. It's a great advancement now. Drug delivery from IV will now switch to subcutaneous. Many of the hematology oncology drugs from injectables, which are IV, are going to subcutaneous and oral. Isn't it great that a patient can sit at home and take therapy, which would have cost him so much in the hospital? He's now able to do it from home. I mean, these are your 6 or 7 advances which I see in practice, which have really changed the way we have looked at myeloma. And today, myeloma is very, very critical. It is very unlikely that a patient of myeloma, even if he or she is advanced, to not go beyond 3 years, which in the past was a dream. Today, it's a reality. We are getting 3 to 5 years easily in most of the, unless they've got issues upfront and comorbidities, then anything can happen. But otherwise, with our level of advancement of care, we can go anywhere from 3 to 5 years. And we've got all of us in this group here. I've got patients beyond 10 years. So that's the way we're looking at myeloma. The advances are huge and it's a great time. I'm not saying people should get myeloma. I'm saying it's a great time for patients who have myeloma to be in today's world because there are so many options available for them.
And Dr. Akanksha, therapies like CAR cell therapy, monoclonal antibodies, and immunomodulators have revolutionized myeloma treatment. Could you elaborate how these novel therapies have improved patient outcomes?
Yeah, so definitely, like Dr. Bhave mentioned, we have a huge basket of drugs now available. With the recent advances, there are multiple drugs and multiple lines of therapies that we have. Which we can offer to our patients. And definitely, with the advent of the monoclonal, which is daratumumab, now we have both the IV as well as a subcutaneous formulation also of the drug. So drug administration has become much easier. Patient compliance also improves, and most of the these agents, they have patient support schemes also. So when they buy a particular one dose, and they get future doses free also. So that's how we are able to support the patients also despite the cost. And you would be surprised to know that we've had the trials which have compared drugs like daratumumab with or without the conventional VRD, which is the bortezomib, and the lenalidomide and dexamethasone. And almost progression-free survival has improved a lot, and almost you can say that disease progression is decreased by 60% in patients who are receiving the monoclonal antibodies. So definitely, it's a very exciting time. This particular decade, we've had a number of these agents come in, and even amongst the immunomodulators, we have drugs like pomalidomide. Those side effects which were there seen with lenalidomide may not be that much with pomalidomide, and they can be used in later lines of therapy also. And when we come to the the latest advances, which are CAR T cell therapy and bispecifics, so CAR T cell is at present, it is in India, it is still in the trials, but in future we'll definitely have CAR T available for treatment of refractory cases who have probably relapsed after transplant and after multiple lines of treatment. So we can offer those treatments also, and at very cost effective rates. Like we know for the lymphomas, the CAR T cell therapy which is costing millions in US, it is almost in India it is at a rate of 25 to 30 lakhs. So definitely cost wise also it will be much more attractive for the patients, and affordability would be higher. And in addition, we have the bispecifics also, which are now available in India. So these agents are also used for refractory cases. So this is basically a drug called teclistamab. So I think we have been able to improve patient overall survival. In addition, the quality of life of the patients is also better because we are able to, even if they relapse, we are able to offer something which can help in decreasing the disease burden and lead to a control of the disease. And of course, the large number of drugs which are available. So we have a huge treatment armamentarium available for the treatment. So I think that's how these agents have definitely improved our practice. And myeloma is a very exciting, I think I would say, exciting disease to treat at present with all these options available.
Right. And it's the most researched one and it's exciting time. I also agree, and survival has increased because of, advent of all these newer therapies. Dr. Kunal, now that we have discussed the treatment, let's talk about the role of diagnostic labs in improving patient care. How can real-time monitoring of disease progression to advanced pathology impact the course of treatment?
So, no, I think the tests which we already discussed are similar, whether we talk about a free light chain or a MRD, those are the same tests which are going to impact. The two things I would like to highlight, especially from the patient perspective in the Indian scenario, the rapidity and the speed at which they can get a clinician appointment today, say for a case like myeloma, if you compare to the Western world, the speed at which a marrow is done, okay, and the speed at which even a higher end test like a flow cytometry is reported is unbelievable. Sometimes we don't discuss these aspects, but in a day or two, you have a comprehensive diagnosis for the patient, and the protocol is written by the clinician. Third day, he or she starting the treatment. I think that is one aspect which the advances has revolutionized, especially in our country. A patient who has reached the doctor, a specialist, will now go with a comprehensive diagnosis within 3 days' time. Yes, the fish will take time. Yes, the prognostication will take time. Yes, the NGS might take time. But the apprehension, the family discussion within 3 days is practically done in myeloma, and so far also for other disorders. So that is where I think with the technology and the automation involved, and even the skill-based test is evolving at a rapid pace. So that is one aspect is the turnaround time from a patient, which I would like to focus on. The test remain the same. We are doing similar tests at different time points. It's not changing much, but also like Dr. Akanksha was discussing about CAR T. The lab has to be ready with CAR T, post CAR T MRD. Okay, we have a drug called anti CD38, like the as Bhave was saying that you have a target. Now the same target is used for diagnosis, but it is because it is very good. Now the same target is used for treatment. Now once the target gets used for treatment, is the lab capable of diagnosing the same disease without that marker? That's the challenge. So we had to be up to the mark that okay, other than CD38, do we have other marker? Now with CAR T, do we require, say in a myeloma, you don't have a challenge, but in other disorders you have that challenge. Then you require to have CAR T cell monitoring. Okay, does the lab have that CAR T cell monitoring to cater to the patient? So as you said, it's an exciting era because every 6 months to a year we have a new target to match or to reach up to in myeloma diagnostics and to keep up pace with that. So that's what we are focusing on.
Right. So as the treatment is evolving, we have to have the pace high. As you have mentioned, that CD38 is a target for treatment as well as for the diagnosis and MRD monitoring as well. Dr. Prakash, clinical trials have played a crucial role in introducing innovative therapies. Could you share your insights on how clinical trials are shaping the future of multiple myeloma management, especially in India?
So at present in India, what we are getting in the clinics is basically the 8 drugs in multiple myeloma, including the monoclonal antibody, daratumumab. We have the melphalan autologous transplant that is a gold standard of any point of time. And definitely the teclistamab is a BCMA therapy. This is available in the clinics so far. So two areas expanding rapidly. One is the CAR T cell therapy, which is still not available in India as a commercial basis in multiple myeloma front. So that multiple myeloma, I think if I remember correctly, there are 8 centers are doing the phase 2 trial is on 8 centers across the India and very evenly distributed with the government and private setup. So this data will be published very soon, and then if it is DGCI approved, then it will be available to clinic also. So that is one of the exciting area of the CAR T cell therapy. I can tell you about myeloma. The other point is the BCMA teclistamab is also already available in the commercial basis, and we are already used also. And now the other issues that are 1 or 2 molecules will be soon to be launched or in clinical trial in our country, I think in 2025 end. So there are areas that are very exciting, and what Dr. Akanksha told, it is very easy to treat or very exciting to treat myeloma, I think in 2025, and when this CAR-T and this new BCMS will be available, I think we can also probably the longevity of the patients will be in the 2 decades for sure. So that will be our dream in the coming years.
Right, sir. So, Dr. Abhay, when it comes to treating multiple myeloma, do you see treatment approaches varying based on patient's age, genetic profile, or disease stage? And how do you balance personalized treatment while ensuring standard guidelines?
Okay, so as far as treatment is concerned, I think in the beginning we have to counsel the patient and the family that, that while myeloma is still there's a lot of excitement and treatment options are available, it still remains an incurable disease. You might get functional cure or you might get control for long periods of time, but eventually they are a relapsing nature. And the question you asked is about whether the patient's genetic structure or advanced disease tends more likely to relapse. Over the years, I've realized that more than the stage of the disease, it's the genes that determine how a myeloma is going to behave. And even over the genes, I've realized how sensitive is the myeloma. You might have an advanced disease, but if the myeloma is sensitive to treatment, they do extremely well. So today's world, I'm not so worried about staging. It might be stage 3 and they'll still do well. They might be stage 2 and may not do well. So in the past, when we did not have so much data availability of talent of tests and interpretation of tests, we were going by stage. And obviously stage 3 was not so good. Today's world is different. More than stage, it is how sensitive is your disease. What is the gene, the genetic structure of your disease? If you got a 17p deletion, that is P53 chromosome deletion, or you've got a 1q1p deletion, or you've got a 414 translocation, these are considered to be difficult patients to treat. They will be treated. They will come into remission. They'll come into control, but the risk of relapse is high. So my treatment strategy is twofold. One, that they have to know that this is incurable and there is always a risk of disease relapse. Two, they have to know during treatment, plasma cells are associated with our immunity. When we are treating the plasma cells, eliminating them, the immunity goes low, so the risk of infection goes high. Therefore, infections during treatment is high because taking care personally of the personal hygiene is very important. Three, they have to tell the caregiver how to take care of these patients because the doctor is only as good as the caregiver. If the caregiver does not bring the patient to us at the time of their need in terms of some adverse event or infection, we can't do anything for them. So treatment, when you start treatment, you have to be you're making the ground clear. The ground reality has to be known. That counseling is extremely important. It takes a long time to counsel the patient at the time of disease. They feel cancer means this is the end. Now we are looking at death. Things have changed in my life. And all of us, all clinicians on this panel have said things have changed in my life. These patients no longer are facing death upfront. They're getting fantastic treatment available. Now, when we started, I said we started with MP, methylene prednisolone, 2 tablets. Today, we are doing 4 drug therapies. Everyone gets at least 3 drug therapies. There's no one who get less than 3 drug therapies. Unless we are really worried any comorbidities like hypertension, diabetes uncontrolled, ischemic heart disease where the heart cannot tolerate medication, you're worried about diarrhea after botulism, you'll get hypotension with that. All those things. There's already a diabetic neuropathy. Botulism lenalidomide will cause more neuropathy. So there are comorbidities that we look at. So we customize our treatment, individualize our treatment to the patient's comorbidities. And of course, in our country, you have to go by what is the financial status of the patient. Like I think Dr. Garg mentioned that daratumumab is the drug. All over the world, daratumumab is used upfront. We can't use it because of the cost. But for those who can afford it, it's a drug which is giving you deep response. Why do you want? I think there was a question asked to Dr. Sanyal. Is there an importance of diagnosing myeloma? Why do you want to diagnose? You want to diagnose myeloma so that you have less damage and you are able to treat it at a much earlier stage rather than going to a later stage when there are already damage to the bone stem. What's the point? So today's treatment is to pick up early, do the counseling, and treat them with whatever is available, which is manageable by the patient financially and from comorbid point of view. But I must tell you, if you see a bird's eye view, it is 3 or 4 drug treatment depending upon the genes, how high risk or standard risk it is. There is no such thing as low risk. Myeloma is there nothing like low risk. It's either standard risk or it's high risk. Okay, so one, you treat, induce remission, control. Then you consolidate what you induce, either with a transplantation, which is a cell autologous transplant, or give more cycles of induction to consolidate what you obtain. And then is the maintenance phase, where you want to maintain the remission and consolidation that you got. This is bird's eye view. All these three together is equal to one line of treatment. And both the clinicians on the panel with me have mentioned that we've got 2 or 3 such lines of treatment in our country. And thanks to Indian pharma, we've got drugs which are available at a much cheaper price. So, like Dr. Kunal mentioned, today we are able to do so much and so much faster in our country because we've got talent, tests, and treatment available to us at phenomenal prices, which the West can only dream of. So our treatments have been phenomenal, and the way we treat is far, far better than what I think the patient in a Western center can get. They won't get an appointment for 3 months to meet the specialist.
Right, sir. Dr. Akanksha says multiple myeloma often leads to complications like bone damage, kidney issues. How important is supportive care in ensuring holistic management of the patient's overall health?
Yeah, so definitely, because like we have been discussing that myeloma leads to bone damage, as well as in later stages it can also lead to cast nephropathy, which is basically the deposition of the light chains in the kidney. So of course we need to give us some sort of supportive treatment to the patients to prevent further damage to the already damaged bone and as well as the kidney. So for kidneys, we usually give monthly bisphosphonates. We also have a drug called denosumab, which we administer to the patients to improve their bone health, and that basically also helps in decreasing the bone pains. When at the beginning of treatment, when the patients present when they have severe pain, earlier we used to even use radiation therapy also to control the pain. Many a times these patients can have fractures in the spine, so we take help from orthopedicians to so that we can do a vertebroplasty, which is basically sort of a cementing of the spine, so that there's no further fracture and you can fill the fracture area with the particular agents. So these are important for the bone as well as the patient's pain management. And in addition to that, you also have to look at these patients, they have a defective immune system, so they are prone to infections. So we usually vaccinate them with the flu vaccines as well as pneumococcal. That is extremely important. And also, some of the agents like bortezomib is a proteasome inhibitor, which causes reactivation of the herpes zoster. So we have to give them certain antiviral agents also as prophylaxis, because these patients are on steroids. They are prone to developing, particular infection which is pneumocystis. So we give Septram prophylaxis. So all this is extremely important, and we have to make sure that they don't. I mean, because they are receiving all these chemotherapy and other agents, so they should not acquire infections. So this is also second most important thing that we need to manage. As far as the kidney goes, of course, in patients who have kidney damage or cast nephropathy, we have to work in conjunction with the nephrology team, so that we can optimize the treatment. So many of these patients have to be in both consultation with the nephrologist as well as the hematologist for the treatment optimization. And of course, because the treatment is long, these patients need to also be managed in terms of the nutrition. So we need to see that they're able to maintain their nutrition overall during the treatment, because that also will impact the overall survival as well as the quality of life of the patient. So I think all these 4 5 things have to be managed, and I think supportive care is extremely important, especially in terms of myeloma, because we have to these patients have to be treated for a longer duration of time, and definitely supportive treatment needs to go hand in hand along with the treatment that they are receiving.
Rightly said, kidney, bones, and infections. These are the things which we have to take care of by vaccinating, by giving proper nutrition, by, be in touch with various teams like for kidney, a nephrologist, and others. Rightly said, ma'am. Dr. Kunal, from a diagnostic perspective, how can patients and caregiver better navigate treatment decisions with the help of clear, accurate diagnostic reports? How critical is to ensure clarity in communication between a pathologist and clinicians?
So, both Dr. Bhave and Dr. Sanyal, I work very closely with. We work as a team in the sense that if the sample has come to us, practically every other patient we are discussing if it's other than routine. The kind of practice, especially myeloma, will be treatment doctors involved, lab is involved, and the patient is involved. So I look at two different scenarios. As Dr. Bhave had started with earlier, we have this condition called as monoclonal gammopathy of undetermined significance. With more and more availability of health checkup packages, more and more of these are being picked up. And if patient Googles it up and says MGUS, he says that okay, I have cancer or a pre-cancer condition. That is where we as laboratorians get involved and say, okay, we need to tell the patient because he's come for a health checkup. He's going to immediately come to the pathologist and discuss the report. Okay, so we have to be careful that okay, I cannot give a 100% clear treat also, and I don't want to worry and make the patient apprehensive that you have cancer or you will get one because only 1% of them may ever progress to become cancer, and sometimes the sensitivity of these tests is so low, or or sometimes we have techniques which are so far sensitive than what is required clinically. So, okay, so that is one extreme. The other extreme is the patient has come to a hematologist or a physician to us. We have done an NGS testing, and you get a mutation of undetermined significance. We don't know, okay, whether this mutation is something which is related to the disease, it is incidental, and what is the clinician going to do the disease? Because the clinician is now going to discuss with me, Kunal, what do I do? What do I tell the patient? So both become a perspective where the teamwork helps, and sometimes giving the clarity to the patient and telling we don't know, we are not sure. These are the statistics, but the patient will say you are talking statistics to me, but I am a single patient, so it's not an easy discussion for the clinician most of the times because they are the ones discussing that. But we discuss as a teamwork. I think that's very critical. And sometimes when it comes to reporting, we put this dilemma in our report. This needs to be discussed with your treating physician. Okay. Sometimes we'll pick up a call and say, kindly discuss the case with us. So that kind of layman language, it also helps the physician to come back because as Dr. Sanyal and Dr. Bhave are saying, the cross reference part. They may not have referred this patient. It might have come from a physician or orthopedic who may or may not be aware of that test. So putting that single line, and I have really benefited that by putting kindly discuss the case with us because the patient now ensures the physician calls him. Okay, so it really helps, and that is what kind of practice we follow, and really helps the way we work together in a team.
Moving on to awareness and advocacy, Dr. Sanyal, awareness plays a critical role in improving diagnosis and treatment. How can healthcare professionals collectively work towards improving public awareness of multiple myeloma in India?
So I just divide the question in two parts. Is the healthcare professional and another is the patient awareness or public awareness. So patient awareness and public awareness is entirely two different things. When you become patient, then you want to know more about your particular disease, and public awareness is general thing. Just to give you a simple example, yesterday I went to some family friend from some tea in the evening. The lady actually asked me, blood cancer कभी ठीक होता है क्या? They are very surprised people. A simple question they asked me. आप क्या करते हो? Blood cancer treat करते हो? Blood cancer कभी ठीक होता है क्या? A simple question, right? So that is a question. So you can't call it ignorant, but it's a question. And that question is very much vibrant in the community that you have to accept. Whatever you do, CAR-T, BCMA, whatever you do, that is the way things are. And other spectrum, 3 years back, I had one lady came to my clinic with some reports and everything. She confidently told me, I had multiple myeloma. Just you diagnose and treat me. And how can I know that is a multiple myeloma? I am also don't know whether you have myeloma or not. She told, I read everything. I did few blood tests. It is multiple myeloma. You just go through. And it was multiple myeloma. So there are two extremes are there. So we have to be very careful about how to talk, what to talk, whom to talk. Dr. Bhave already mentioned about the monoclonal gammopathy having determined significance. So any patient came to at the age of 75 and they asked me that whether I need treatment, I tell them if you want to get treatment, you have to live at least 20 years. So you have to live up to 95 years. Because every year you have only 1% chance of progression. So only 20% chance of progression, but out of 5-1, you have to live up to 95 years first. Then only question of treatment will come. So these three things have to be very clearly to be understood. So public awareness, clinician awareness, I start from the general practitioners. Most of the patients with the backache and fatigue and everything, they go to general practitioners. So general practitioners should be aware about that, what anemia is. Very basic thing about the anemia definition. I think any hemoglobin less than 13 for male and less than 12 for female to be little bit investigated. And if it is not nutritional, then you think something else. And obviously, the multiple myeloma takes a lot of, or any plasma cell related problem takes a big dig in the entire anemia spectrum, I believe. So educate the general practitioners, physicians, extremely important. Orthopedicians. See, they are surgeons. They are mostly busy with the renal, sorry, they're busy with the knee replacement, knee replacement, hip replacement, all these things. They are not bothered about a little bit backache here and there. So those clinical histories are extremely important, and for them to understand that, okay, this is a backache, this is something unusual backache, which you don't commonly see, or not positional backache, postural backache, not autoimmune disease backache. So these two community, I think, to be very much to be involved about that. There is a disease called multiple myeloma. What Dr. Kunal told us, through the electrophoresis immunofixation, they give a diagnosis. This much awareness to be extremely important, I believe. So for me, one liner: if any anemia, unexplained, not nutritional, little bit ESR is high, albumin globulin ratio is reversed, any creatinine is not explainable, which is little high, and any backache, should be investigated for multiple myeloma in the general practitioner's level. That is one very important thing. If I go to the collectivity, we call it the general public awareness. I'm going back to my first question, that people should know that multiple myeloma is a blood cancer, number one. There is no specific symptom for that, mostly the non-specific symptoms. But if non-specific symptoms are not corrected with their non-specific measures, then you should go for the specific diagnosis and specific measures. And if you can come out to multiple myeloma, and multiple myeloma is a very treatable disease, that message to go. So the unnecessary, whenever you call about a cancer, everything falling on your head, anyone's head. So most important thing, multiple myeloma is a treatable disease, very well controllable disease, and most important, after 3-4 months of therapy, the many of the multiple myeloma patients can go back to their job, they can earn, they can live their normal lifespan. And multiple myeloma is a very funny disease. There are many people who are 10 years, 12 years, 15 years, they do very well. And yes, there are some group of people that even 2 years, whatever you do, they don't live. So you have to little bit sensitize the patient community, all these things. But too much information for particular disease entity to the community, I don't think is a very good idea. I have a long discussion with Dr. Kunal, because I remember in our Newburgh meeting, there was a discussion going on that serum protein electrophoresis should be the screening test or health checkup test in anemia screening, right? Kunal, we discussed that. I think it
Correct.
is too overambitious thing, and I, as a clinician, strongly discourage to be continued. So that is the way my message is. So you have to be very careful about what to talk, whom to talk, and how to talk.
Right. So I would like to take closing remarks from my two speakers left, Dr. Abhay and Dr. Akanksha, that what message would you like to give, what policy changes, what advocacy groups have to do, for the multiple myeloma. I'll start with Dr. Abhay first.
I think Dr. Sanyal has summarized it very well just now. Uh, as far as making a policy, see, multiple myeloma is such a varied presentation. It can be right from the orthopods to the nephrologist to the physicians who can't seem to get the hemoglobin up. It can be endocrinopathies. It can be neuropathies with a neurologist. Its presentation is too wide, protein manifestations, and therefore to come up, there's no one test. Like say in CML, you got translocation of 922 is equal to CML. We don't have one test. We got a thought process and awareness. I would just say myeloma presents differently in different people. The earlier the pickup through proper awareness is important. Those who have got a persistent bone or back pain which is not getting relief, those whose creatinine doesn't seem to come down, they have got a foamy urine or frothy urine, those whose hemoglobin doesn't come up despite the best measures, those who experience neuropathy imbalance, Those who are getting pathological fractures or easy fractures where there's not much of an injury are all candidates for assessment. It need not always equal to be myeloma, but they need to be assessed. Whether it comes out myeloma is a different matter. But let's not miss out myeloma because we all feel it's a highly treatable disease. Therefore, picking it up early if possible or picking up wherever it is and treating them will change their quality of life and improve their whole well-being so that they can take care of their life in terms of productivity amongst their family and also in the community and still be productive in terms of earning. We want to give them a quality of life where they go back to as much a normal life as possible. But that we can do only if we pick it up early. So awareness is important, but this should not create panic or fear that if I got back pain, it's going to be myeloma. So that is very hard. That line is too thin to explain on a webinar or on a discussion such as this. It's their interaction with their general practitioner or a family doctor, which is extremely important because that is the pillar of our society, the GP or the family doctor. When they have persistent symptoms, their family doctor knows the history. And they say, no, for you, this is unusual. You need to be tested. So, it's a collective effort from everybody concerned, not out of fear, but out of the desire to know and diagnose on time.
Rightly said, sir. Very good message. And Dr. Akanksha, your closing remarks, please.
Yeah, I feel that from the government's point of view, I feel that there should be more trials that should be there for these particular, especially the refractory patients, because they are the unmet need at present, patients who don't respond to the initial lines of treatment. So more research funding into trials. And I think second, I would say that many a times, not just for myeloma but even other diseases, there's a lot of discrimination at work, especially when the colleagues and the workplace people, they get to know that the patient has a particular disease. And even I've heard patients saying that for their future prospects for jobs also, sometimes they question about their disease status and how what is their life expectancy. So I think that should also be something that people should be made aware of, that yes, I mean there should not be any discrimination at work for especially for patients who are suffering from myeloma. So I feel that these are some of the points, or probably the unmet points that need to be focused on more. For I mean, definitely the advocacy groups are doing a great job in providing financial support, psychosocial support. But these two, three things are something that we need to work on.
Right. So, with that note, I'll conclude the session on multiple myeloma, which is a type of blood cancer. So, if you have a backache, if you have unexplained anemia, which is specifically not nutritional, if you want to, just be diagnosed and picked up early and get treated, just go to a doctor. Thank you so much for joining us today.
Thank you so
Thank
much for
you.
having
Thank
us.
you.
Thank
Thank
you.
you.
Bye.
Bye. Good evening.